It is my pleasure to welcome you all this afternoon to the American Association for the Surgery of Trauma's virtual Grand Rounds, Experts in the Hot Seat, hosted by The Ohio State University. We have some great cases to present and are hoping and expecting some great discussion. My name is Jennifer Knight Davis. I'm a professor of surgery at The Ohio State University in Columbus, Ohio. I serve as the director of emergency general surgery, and I'm the acute care surgery fellowship director. I'm also a committee member with the AAST on the acute care surgery committee, the program directors committee, and the emergency general surgery ad hoc committee. I do need to note, I'm going to share my screen here. I do need to note that CME is no longer offered for the live grand rounds. However, should CME become available as an archive session, attendees will be notified via email to claim CME credit. I'd like to introduce our panel of experts. Dr. Sharon Henry is the Ann Scalia Professor of Trauma Surgery at the R. Adams Cali Shock Trauma Center at the University of Maryland in Baltimore, Maryland. She has an esteemed academic career focused on advancing the care of injured patients around the world, with her work leading ATLS, and is the current president of the Pan American Trauma Society. She's the chief of the Division of Wound Healing and Metabolism at Shock Trauma, a personal mentor, and a die-hard Baltimore Ravens fan. Dr. Jen Hartwell is the Associate Professor of Surgery and the Section Chief of Emergency General Surgery in the Acute Care Surgery Division at the Department of Surgery at the University of Kansas Medical Center. She actually grew up in Ohio, which is really nice having us hosting, where she did her got her undergraduate degree in Ohio at Miami University Medical School at Wright State in Dayton, and then completed her general surgery training at the University of Illinois in Chicago, and then completed her fellowship at the University of Tennessee in Memphis. Dr. Hartwell has a special interest in surgical nutrition and is an advocate for physician and learner well-being. She enjoys spending time with her husband and 4 children when she's not working. Dr. Andrea Joseph is an acute care surgeon with more than 20 years of experience managing critical ill and injured patients. She completed her residency at Brown University Warren Albert Medical School and her fellowship at the esteemed R. Adams Cali Shock Trauma Center. She has a particular interest in research in interpersonal violence education. She was honored as the Trauma Medical Director of the Year from the American Trauma Society, and her commitment to healthcare extends globally as she serves as a consultant to the government of the Commonwealth of Dominica. We have 3 cases we want to present today that will span critical care, trauma, and emergency general surgery. And these will be presented by fellow and faculty members from The Ohio State University. Our first presentation is going to come. Julia, do you want to start with your case? Julia Coleman is one of the faculty at Ohio State. She will be presenting our first case, a trauma case.
Awesome. And I'm also joined by our fellow as well. She can present after me. We'll get started with the first case here. Okay. So the first case, your trauma pager goes off. It's a level 1 trauma and it says gunshot wound to the neck. So you get a call from an outside level 3 trauma hospital, and which patient was taken there after an altercation with police, where he was shot in the left shoulder, the right anterior thorax, and the abdominal right lower quadrant. And then he shot himself in the neck. He was taken to an outside hospital ED where there was concern for an airway injury. So zone 1, 2 neck wound, and in the bed of the wound, they were concerned they could see a partially or fully transected airway. They were able to intubate him and started 2 units of whole blood for hypotension, which he responded to. And so they called and want him transferred to OSU for further management. So that's what you know. What are you preparing in the room? What are your concerns, things that you're thinking about as you're getting your room ready for this patient?
Dr. Henry, at Shock Trauma, you guys have, I did my fellowship there. Obviously, D'Andrea and I know how it works. There's a really nice system of alert, advance notice. How does that work at Shock Trauma, and what kind of resources would you be pulling together for a patient like this?
Yeah, so we would be the team would be preparing for the patient's arrival with, concerns about, the airway is hopefully taken care of, but you have to assure that that's definitely in place and secured well. It's unclear to me if he's actively bleeding from the neck. Obviously, you want to be prepared to resuscitate this patient. We have whole blood available in our refrigerator, as well as components, FFP. This is a patient who's likely going to need a trigger pulled for a massive transfusion. I'm thinking, we haven't heard any vital signs, but that's certainly something I'm thinking. This person hasn't had a lot of, I don't know what the interaction with EMS has been, so it would be unclear to me whether to expect that he would have already received TXA. If he hasn't, and it's within, it hasn't been a prolonged period of time, greater than 3 hours, I would probably want to also make sure I got this patient TXA. And you're going to draw the bloods, you're going to have chest tube stuff available. This guy is shot all over. He's got torso problems. He's got an intra-abdominal, potentially an intra-abdominal trajectory, as well as this significant neck trajectory. So, we have sufficient staff that we could probably get 2 teams involved. If we had to operate on the neck and the belly simultaneously, we would be able to manage that. If this was a smaller hospital, that obviously wouldn't be the case. But those are the things I'm thinking about. Do I need another attending team in here? We have our ORs are on standby, so our OR is going to be ready and easily accessible to us once the patient's assessed and we determine whether we need to go there. But if we can stabilize this patient in some way, shape, or form, it may be ideal to get some imaging to see, where do we start? Do we start in the neck? Are we starting in the chest? Are we starting in the belly? I think these are the things that are going to sort themselves out as the patient rolls in and we start getting more information.
Yeah, that's a great segue. So call EMS. They say, "Gosh, he's gotten hypotensive again. We don't have any blood products in our ambulance. We're starting crystalloid. You've got a cooler in the room, a chest tube." We call the OR, say, "Hey, be ready for us. We'll see you soon." So patient rolls in on his primary. He's got an ET tube that's in place, good end tidal oxygenation. He's got a clear injury, likely a partial transection of his larynx at the base of his neck wound, but he's intubated distal to the injury. He's got bilateral breath sounds. He's tachycardic to the 120s. He's on some low dose Levo that was started in transport. So what, Dr. Hartwell, what's next? We've gone through that primary. What are your thoughts?
So I would echo everything that Dr. Henry said in trying to triage where are we starting, and maybe we're going in 2 places at once, but I would immediately get a chest x-ray to try to figure out, do I need to immediately address the chest?
Okay, great. You do that. So you say, "Oh, he's on Levo," but lucky for us, we've got blood in the room. So you start a unit of whole blood, immediately comes off the Levo and is then normotensive, though tachycardic. So he's at least responded in his pressures to the blood. So you get this chest x-ray. So what are your thoughts on this chest X-ray, Dr. Joseph?
So I am curious about the diaphragm and there's some deviation to the left, which suggests loss of volume on that side. It certainly looks, it's hard to tell on the screen, but it doesn't look like fully expanded lung, among other things. Although
Indeed.
the tube is in the stomach, the NG tube, so I'm sorry, it's in below the diaphragm. So not so much a diaphragmatic entry, but certainly there's something going on there with the lung. And you can see the shrapnel on the right side as well. I mean, there's so much you can tell from x-rays, and sometimes I get a little frustrated with the ultrasound and the sliding because you can get much more information, I think, from just a simple chest x-ray. And I think this tells a lot there. You
Yeah, a
did say
picture
that
tells
he's-
a thousand words, or whatever the saying is. That's true here. So little difficult to tell, but he's slightly right main stemmed, which is perfectly
Yeah.
fine. The ED that intubated him at the level 3 saved his life. I sent them
Yeah,
a message actually
sure.
after this.
Mhm.
But you're right. Your first question is, wow, I didn't realize that police use shotguns and buckshot,
Right.
but that was apparently the case here.
Yep.
Yeah.
Nevertheless, you are totally on point, Dr. Joseph. We put a chest tube in the right, had about 500 of blood that came out, and then stopped thereafter, had some nice re-expansion, pulled his tube back. After that, got a pelvic x-ray, again, shows a bunch of shrapnel in the right lower quadrant corresponding to what we see on physical exam. And speaking of, on our secondary, again, we had this gaping neck wound with concern for laryngeal injury. There was some venous bleeding tied off. He had a single penetrating injury to his left shoulder, single penetrating injury to his right anterior thorax, just below his right nipple, and then 6 penetrating sort of buckshot pattern injuries in his right lower quadrant. Get some of his labs back. He's got a slightly elevated lactate. He's acidotic. And so the next question is, where do we go from here? Do we go to the scanner? Do we go to the OR? Do we discharge home? What's next?
Yeah, this is a patient, he's stabilized after you put the chest tube and he got a unit of whole blood. I think putting him through the scanner is not a bad idea, because that really tells you what you need to do. I mean, that buckshot in the area of the hip, I don't know what that could be anything, or nothing, right? And also the same with the scatter. We know that it did at least reach the chest. Is his liver damaged? Is there ongoing output from the chest tube that we can assess as we go along? But the fact that his lactate wasn't super high, if I recall, his base deficit is not super high. So you're thinking the degree of his shock is, it's not great. He's not perfect, but he's not terrible either. I don't know if you have coagulation studies yet to say where he is on the spectrum of hypocoagulability at this point in his management, but that's stuff to keep in the back of your mind and make sure you're staying up with. If he's getting whole blood, he's probably going to stay pretty close to normal, but that's something else to keep an eye on. But I think I'd want to get the imaging personally, because I still don't know what cavity to go in.
I may or may not have been the trauma surgeon on this case, and I'm relieved that one of my heroes, Dr. Henry, said that she would do what I did, which is in this hemodynamically stable patient, albeit a little bit of tachycardia, I said, let's go to the pan scan just to figure out what our game plan is.
Yeah.
So we indeed did that. And you'll see this scroll through, but I'll highlight some of the read of it, which is paying attention, one, to the liver. We had an appropriately placed chest tube there. And the liver is full of buckshot, with about a 50% parenchymal hypoenhancement consistent with a grade 4 liver lac with some hemoperitoneum. As Dr. Joseph pointed out earlier, possible injury of the right hemidiaphragm, something going on there. You can already tell from a chest x-ray. Had also mild colonic hepatic flexure thickening. So when this rolls back through on the CT scan, you can pay a little closer attention to it. But there was a piece of shrapnel just at the bottom part of the liver, right next to the hepatic flexure. And there was some colonic inflammation around that. So concerning for a possible, hollow viscous injury. You'll see it scroll through here, right coming up there.
Yeah.
And then had some scattered metallic fragments in his right middle and lower lobe, as you saw, and some pulmonary contusions, rib fractures. And then, in this right lower quadrant, it actually looks like most of the air tracking and shrapnel is just tracking into the retroperitoneum. So not obvious that there's a real bad pelvic injury there, but at least gave us a little bit of an idea. So, what next? The plan here is to go to the operating room, but maybe Dr. Hartwell, you can talk about what's going through your mind as you're looking at the CT scan and they're getting ready upstairs. What are your priorities? What's going to be your approach? Are you going to call for help? Who do you call? What do you want to make sure you have in the room?
So at this point, is his neck injury stabilized? Is he bleeding anymore from the neck? Or is that hemostatic at this point?
Pretty hemostatic.
Okay. So he's not dying from his neck injury. We've addressed
Right.
the chest injury and how much output? 500, you said, from the chest tube?
Yep, pretty minimal since then.
Okay. So this is leading me towards, I would start in the abdomen. I think that's where I have the deepest concern for something I need to do first. So I would be telling my OR standard laparotomy things, have the Belmont set up or the rapid infusion transfuser set up in the room so that in case he drops his pressure, we need more blood, we have that ready to go. In the operating room, I'm obviously going to do a full-on laparotomy and take a look at everything systematically, but I'm most worried about the liver. This is a super tough injury to manage. Deep intraparenchymal bleeding is really difficult to manage. So opening them up, I want to take a look at the colon and make sure that's okay. And if not, I would do a resection and probably leave him in discontinuity at this point. And tell the OR that I would probably want the temporary abdominal closure device prepared. It's probably someone I'm thinking may need to pack and then go to interventional radiology for catheter directed hemostasis.
Yeah,
We saw extravasation or like a vascular injury in that liver or frankly, much in the way of free fluid, and it's not coming out the chest, which suggests that his liver isn't actually bleeding.
Yeah, I agree.
Frankly, I would in the operating room be very ginger with that and not want to do much with it and not, don't poke the skunk, as they say. They have many ways to say that same thing that aren't nice, but I think I would try not to poke the skunk here. Like I wouldn't go searching for the hole in the diaphragm necessarily.
I definitely agree.
Yeah.
I don't think I'm going to talk myself out of not looking at the colon. So
Oh, no, absolutely. I
Yeah.
agree. I 100% agree that you want the thing that you don't want to miss is a hollow viscous injury.
Yes.
And that's the thing that you're going to miss from the imaging you have.
Yeah, I completely agree with Dr. Henry. And that being said, I don't want to lull myself into thinking this is going to be just let's look at the colon and get out like
Yeah.
that. So that's the rationale for let's just have everything in the room. Don't open it, but I want it handy.
Yeah.
Yeah,
And
so-
Dr. Hartwell,
yeah.
Go ahead, Dr. Joseph. Sorry.
I just want to jump in here for a minute. So I have a couple of questions because I don't feel like I have enough information. I agree with everything that has been said so far. What I don't know is you said he received 2 units of whole blood and he responded, but he's still tachycardic. Tachycardia in a patient at that age is evidence of instability. So has he slowed down? Did he tank when he was intubated? Because that's one of the ways you can find out. They will maintain their blood pressure, but then tank as soon as you sedate. So if he were to remain stable, as in his heart rate did not increase, his blood pressure didn't drop, yes, of course, the studies and then explore him. I would be extremely ginger with the liver because I am concerned about a retrocaval injury as well, because it's in that area where that possibly could be an issue. I do think I would call IR and have them available on the alert in the area should I get into, a little bit of doo-doo. I very much want to look at the colon and surrounding and everything around it, and I want to look at his ureter as well, and he's just in that area where there's problematic. Yes, enter the abdomen first, but I am not entirely comfortable with that he's not going to tank with whatever's going on up there. So my question to you, we saw only an abdomen. When he was on the table, did you look at an angio of the chest, looking to see if there were any injuries up there as well? Or is he stable enough to have undergone evaluation of the intrathoracic neck injuries? And having been a disciple of, Dr. Henry and shock trauma, no, I'm not calling anybody yet, but I do think that I would want my backup to be aware if we actually have to go in at the same time.
Yeah, all beautiful points. So we started mobilizing to go upstairs to the OR. Dr. Hartwell really laid out nicely all the things we're thinking about, including some of the hemostatics and the suture that I'm going to want in the room for the liver if we have to dive into that, hoping we don't.
I love sewing the liver.
Yeah, and I was like, blunt tip, Chromix, bring him in the room. And Dr. Henry brings up another point too about IR collaboration. So I had actually texted the IR attending that was on call to say, hey, we may be packing and coming to you. And Dr. Joseph brings up a great point. While I wasn't from the Maryland crew, I was from the Denver group. So I hadn't called my backup or anyone else in yet. I was going to see how we did once we got up there. And
Sure.
once we got up there, we get the patient onto the OR table, and he now becomes hemodynamically unstable. And so it wasn't hypotensive, but I guess he timed it well. The great place to become hypotensive is on the OR table in front of a trauma surgeon. So when that happened, for me, belly was the priority. But I actually called ENT to come and help with the neck while I was working in the belly. Because I wasn't sure what I was going to get into and how quickly I was going to be able to prioritize that. So ENT came in. They actually did a trach below the level of the injury and the neck wound, and did a primary repair of a laryngeal partial transection. While they were doing that,
I got to ask you about that, because
yeah,
if you have him intubated beyond the level of the injury, your concern is not airway, it's bleeding, right? So and shock. So you are focused, the focus is on the abdomen, getting control of the bleeding, whatever is causing that bleeding. But I would be thoughtful about whether I would want to spend the extra time repairing the larynx in a setting of a patient. And I don't know the timing from the insult to where you are right now, but I would just be thoughtful about that and how long that would take.
no, great point. Yeah, we did the classic prep from chin to knees, and they started working in tandem while we were doing our part of the case. They started, I think, probably about maybe 5-10 minutes after we were going down in the belly. So opened up his belly, found hemoperitoneum packed, and his liver was totally speckled with ballistic fragments. Like every centimeter there was one, and I did not want to wake the bear there. So we did packing around the liver, and at that point did a full Cattell-Brasch, looked at the colon. Colon actually looked okay. And then at this point, he was getting transfused blood. He was acidotic. He was cold. So everything looked pretty hemostatic with the liver after the packing. The colon looked okay. So we decided to leave him open with the idea that we could get him resuscitated in the ICU and then come back, make sure that colon truly looked okay and there wasn't a delayed blast injury manifesting, and that the liver all looked hemostatic. So I'm going to skip ahead now to the last part, which is we took him back to the OR the next day. Colon was viable, liver hemostatic, let the JP drain by the colon, close the fascia. Great. So we're all high-fiving. We think everything's good. On post-op day 3, he still has that chest tube in that we put in down in the trauma bay, and still has that JP drain. And all of a sudden, ICU calls and they say the chest tube is putting out what looks like bile. And they test it for bilirubin, and it's elevated. So they call you and they say, what do you want to do? How do you want to approach this? Dr. Hartwell, what are your thoughts?
Well, you have a couple of options. It depending on, I agree with not looking at the diaphragm. You don't want to poke the liver. You have a couple of options. Some of them are good and some of them are not good. One option is go back in the belly. It's only post-op day 3. Just go back in. He's hemostatic now. Find it, fix it. Some people feel comfortable looking at from a thoracoscopic standpoint, approaching this from the chest. Is if it's small, some of these just seal on their own and you just ride it out. You have a chest tube in place, so you seem to have drainage control. Down the road, if you're not feel like that you're not controlling this, there's always things like PTC tubes and things, but this just prolongs a really bad injury. And a bilothorax is awful. I've taken care of a patient when I was at Grant in Columbus. Awful, awful, awful problem. So is he's hemodynamically shipshape at this point, like kind of cruising?
He's hemodynamically stable. He has a chest x-ray that doesn't show, an increasing effusion. It seems like the chest tube is well controlling the efflux.
Well, I'm very interested to hear what Dr. Joseph and Dr. Henry say. I think in my hands, I would just bite the bullet, go back to the OR through the abdomen. He already has an incision there. Look for the injury and close it if I can get to it.
Yeah, I think there are a couple of things. The quantity of output is how much? I mean, it looks like a fair bit, but I don't know over what
Yeah.
period of time that
So
was.
it put out 300 over 24 hours, and the next 24-hour period, right before we enacted our plan, it had slowed down. It was starting to slow down.
Okay. So, I mean, when you have a bile leak and it's intra-abdominal, let's say this was all just coming out of the JP drain, you probably would just sit that out, right? You would wait it out. But certainly, we here at Shock Trauma had tended to use ERCP fairly early in these patients and done sphincterotomies and stents with in an effort to decrease drainage from high output fistulas, and it works very, very well. Now, would many of those have stopped on their own? Perhaps, but you don't know that unless you wait, right? So an option would be to do an early ERCP and do a sphincterotomy or a stent or something to be sure there is the path of least resistance is going to be the way you want it to go. At post-op day 3, I think going back to do the diaphragmatic repair could, you certainly could do that, and probably that would be okay depending on where it is, because it could still be super difficult to get to, and mobilizing that, if you stick your finger through a hematoma and stir something back up, you could be quite sorry for that. You could certainly better place drains so that things drain out the abdomen rather than going through the hole, being the path of, again, of least resistance. So I think those are the options that there are.
Yeah.
To go. I don't know, Deandra. Yeah.
Yeah, I actually think I would take him. All those options exist. I would lean towards going through the chest to look at the diaphragm. If it's a tiny hole, like put a scope in, it's a tiny hole, maybe stick like a drain chest tube, and then also draining from below. And I would go to ERCP. Having seen those bile leaks and what they do to the lung, I would prefer not to have it sitting there. So at minimum, I could kind of, do a little bit of drainage, irrigate it out. But if it's I would stick a scope in. I wouldn't go back through his belly to push the diaphragm, just because, again, of the concerns that everybody expressed of poking the bear, right? So the lung would be my preferred approach in that setting. The challenge, though, would be in positioning him, because you're going to have a person with a vac in place, and it's going to be a little difficult because you want to get his chest up well, the other side, to be able to kind of stick the scope in and put it where you want to see it. So that may be a little bit of a challenge, but I would still start with going through the
I think that's a great
just-
point you make there, Dr. Joseph, about like at least
thank you.
doing a VATS to clean that bile, because that, you're right, that can be very hideous in the chest and lead to lots of inflammation and problems. And I think I would probably, I think the VATS is a great way to go. Whether I would do that in combination with ERCP, just because I think that's our style, I want to say,
think it
but I don't know
depends.
that there's really literature that would necessarily say that you have to go to ERCP with that volume of effluent. You could certainly fix the hole. It's going to be better for the hole to stay fixed if it's not constantly bathed in bile. So that is one of the reasons I think doing the ERCP and trying to cut down the volume is a good idea, just because it's going to help your repair hold by not being, bathed in bile. But I think it's a great idea to, if you have the skills to be able to do intrathoracic repair. The problem is, depending on where it is, some of those angles are difficult to see from a VATS. So, maybe
Yeah.
you may not be able to see it properly to be able to fix it. But if you can, certainly that would be a way to stay out of injuring the liver for sure.
I'll just throw it out there that I'm guessing this is not a single hole, since this was like
Mm.
buckshot.
Yeah,
I'm guessing
yeah.
it's almost like a
That's a good
screen.
point. That actually
So
is probably
the more that we're
multiple
talking
holes.
about it, I'm kind of leaning towards the maybe stick a scope in and see what it looks like, but probably
Mhm.
you're gonna have to
Yeah,
get the
to go.
RCP, I think.
Yeah, yeah. And honestly, I know we're all about minimally invasive and I support that, but we're talking about saving a person's life and doing the right thing. Unless, I just talked about the angles, I don't think there's anything terribly wrong if you have to convert to a mini thoracotomy. It doesn't have to be a huge one to get to where you need, unless you have the expert in-house. It all comes back to the resources, right? I mean, I always tell people at shock trauma, you can do anything and everything because everybody's there. But other places are not as well resourced. And so you have to think within the parameters of what you have as well.
Yeah, I love this discussion. This is great. And all those questions I brought up now on the slide are exactly what you all sort of weighed, which is, do we take him back and open his belly? There was some concern about doing that, poking the proverbial bear. There was some discussion, do we go into the chest and do a VATS? Even though it seemed like whatever was leaking was small volume and fairly well controlled with the chest tube, his chest x-ray was pretty clean. So we debated that. And again, as Dr. Hartwell brought up, we thought, whatever hole is there, there's probably a lot of them and they're all really small. So if we are going to focus on doing a diaphragm repair, what would that look like? So ultimately, we decided to start first with an ERCP and then trend the chest tube output over the next 24 hours. And if that didn't improve, to take them for a VATS the next day. So started with an ERCP. They indeed found a biliary leak that was rather distal, but significant. They did a sphincterotomy, placed a plastic stent in, and the next day his chest tube output essentially went to zero and was removed. His JP drain also predictably slowed down quite a bit as well. And so he's still in our ICU now and recovering from all of this, but ended up avoiding a VATS. I suspect he's probably going to have some fibrosis in there, and I hope no one ever needs to go in there now. But that
Is
was
he
a choice.
extubated?
And he's on a trach now and has been CPAPing.
Fantastic.
Yep, so
Great.
he's doing well. Thank you so much for your input on that case.
No, great job. Great work.
As we're transitioning to our next case, there is a question from our participants asking if each of you have a protocol to go directly to the operating room, and what might be some criteria for a patient who is arriving by helicopter, for example, to go to the OR first and not even maybe go to the trauma bay.
I'll say we do not have a direct to OR policy, and I won't go into all of the reasons why, but we found that it would overutilize OR resources, and so we decided not to have that policy. So we
Before,
stop in the
you
ED.
know, yeah, I want to jump in because I think I know what Dr. Henry is going to say, but at prior institutions, there's one institution where we do have a process. We had a process when I was at Cooper for taking the patient from the helipad trauma bait straight to the OR, but that was very specific. There was no protocol in place so much as it was left to the attending discretion, at least at the time that I was there. That being said, I do not believe that this patient is the candidate unless he were unstable immediately at the time to be a direct admit to the OR. We all agreed that he needed additional information, but I'm curious, Dr. Henry has to say.
So in our center, because our ORs are literally, feet away from our trauma base, the direct to OR component has not been as useful to us. I think we would probably, like Dr. Joseph talked about, I think we would overutilize our OR resources. And I have to say, I remember a case probably a year or two ago that I listened to the story from the field, and I made the decision to admit the patient directly to the OR because I just knew it was going to be this terrible neck wound that required immediate exploration. And we, did all the things. We brought the patient directly to the operating room, and it was like a little thyroid vein injury that turned out to be really an overuse of our resources. We saved him though, but so I think it depends on your setup. Now, some places that have this direct to OR policy have these ORs that not only are hybrid, but also have CT scans in them, in which case that makes sense because you can do everything you need to, your whole workup. And the folks in Japan, even if you look at those wonderful operating rooms that are fully equipped in Japan, where they roll the patient in, they can do the CT, they can do the angio, they can do then do the operation right in the same space. Those places are amazing, and I think if you have a setup like that, then I think it makes sense. But and again, if your OR is way far away, or there were issues about you knew the patient was going to be unstable, then I think, but it really does have to be a protocol, because just doing these onesies and twosies, how do you admit the patient? How do you make sure you can open the Pyxis to get the drugs that you need, or get the massive transfusion going, and all those kind of things? Those have to be worked out before the guy actually, or the gal actually, arrives to the operating room, and you're stuck there trying to figure it out.
Outstanding. Thank you so much. We're going to move on to our next case. Dr. Gibson is our finishing her first year of our acute care surgery fellowship, soon to be one of the people moving into the hot seat, but she's gonna present you with a case.
Hello. So this case is from the intensive care unit. So as soon as I get to work, okay. So we're up in the ICU, you're managing the ICU, you get a call, transplant service has got a liver on the table. They're going to be bringing the patient to us post-op. We know that the patient is a 61-year-old male. He's got MASH cirrhosis. His MEL was 14. He had some esophageal varices. He has a history of some heart issues, but EF was normal pre-op. But he had a PCI about a year prior to transplant. He came to us for his transplant, and the fellows and the transplant team had informed us post-op that During the transplant, his hepatectomy was very difficult. They had to perform sharp dissection to get the liver freed from the cava. There was a significant amount of bleeding from the cava during the case. They had to suture repair it. They noted that the liver was congested at the end of the case. They thought it was from the amount of resuscitation because he had received in excess of 40 units of red cells as part of a balanced resuscitation. So they left him in biliary discontinuity. They put an Apthera on and they brought him to us in the ICU. So day 0 of his ICU course was his transplant. On day 1, he went back to the OR for washout. And initially they were hoping to do a biliary anastomosis. During the take back, they noted the cava appeared very stenosed. So they called IR. On table angiogram was performed, or venogram, and they took some biopsies because the liver still looked quite congested and just did not look as healthy as they were hoping. This was the venogram image done in the operating room. You can see how narrow that cava lumen is. They measured it at about 3 millimeters. They stented it. They did get an improvement in outflow, and they thought that things were going to be okay. Unfortunately, over the next 12 hours in the ICU, he became progressively more unstable. The liver biopsies were processed as rapidly as possible by pathology, ultimately showed over 90% necrosis of the graft. So over the next 12 hours, he progressed to 4-pressor shock with profound metabolic acidosis. pH was 7.19, and that was actually a decent pH. Lactate was in excess of 17. He was encephalopathic, he was in renal failure, and he was in respiratory failure. So what can we do? The ICU says help, or the transplant team says help, ICU, fix this. Well, what can we do?
You have prayers?
Yeah. For sure. I mean, the only thing it is the first comment I have, and I don't know completely what I do, but the first thing I'd be thinking about is what are all the things that the liver does and what can I take over? So helping with blood sugar control, acidosis, like the trying to manipulate the things that I can that the liver does, which we don't have a whole lot. I'll stop there. I don't know. This is a really bad
Yeah.
situation.
Do you,
I have a question I'm sorry, Dr. Henry, go ahead,
no,
please.
go.
No, you made mention of the several sutures that were used in the, is it possible that that was actually closed? And the same questions. What can be taken over? Was that closed completely? Although the stent, you still stented it, he still had necrosis. So is this some sort of rejection, T-cell mediated rejection? Is there any possibility of doing LSO, like an external liver support? It's a pretty dire situation when you have 90% necrosis and you have greater than 17, the liver is not working, is what this is telling you. And so while I'm thinking, I'm going to pass it over to Dr. Henry.
Well, I want to know, is he a candidate for another liver? I think that's an important question, and how likely is that to happen? Because if he isn't, then it's like, you do the things that you've just said, continuous FFP, blah, blah, blah. If he is, do you have Mars available that you can use for to support him until such a time that you can get a new liver for him? Or do they really think that this liver can recover? Because it seems like with that tiny bit of outflow, I don't know. It seems unlikely that liver is going to rebound, but again, the transplant service often has a difficult time giving up on these organs.
Yeah.
Once they put some effort into them, even though their patients are really, going severely left.
Yeah.
So I think those are the things I want to know. Is he a candidate for another liver? Do you have ability to use this sort of liver dialysis to support him in the interim while you wait for the next organ to be available? And if not, it's gonna be whack-a-mole.
Right, right.
You know, find the wrong thing, fix it, find the next wrong thing and fix it.
Yeah, I'm also curious that the liver was dusky prior to even the issue of the outflow, it appeared to be, because immediately as they put it in, it seemed, was I reading this wrong, that you said that there was some problem, that it was already dusky, so that it appeared to have been something going on prior to?
It was congested at the time of the initial surgery. It didn't appear dusky until post-op day 1.
Oh, okay.
Until they
Okay,
went back
all
for
right.
the return. So originally they thought it was congestion due to resuscitation because of the amount of blood products. So these were all the same kind of questions that we had. And as you aptly put it, we were playing whack-a-mole in the ICU, trying to keep things going until we had a plan. And if you'll forgive my little detour into nerdiness for a second, for my fellows who are on the line, I had never seen this before, and this has been described as toxic liver syndrome. It was described by a group back in 1993, and it's caused by complete liver necrosis. You get profound cardiovascular collapse with shock, renal failure, and respiratory failure. They don't know exactly why these people get this sick, but they think it's because of the toxic metabolites from the liver getting dumped into circulation, and it causes this runaway process, which, as you guys all alluded to, is 100% fatal unless they transplant. So we knew that we wanted to transplant the guy again, and transplant was working on that. The problem was, how do we keep him alive long enough to get another liver? And so they took the liver out.
Mm.
So
This is interesting. I
Mhm.
just want to mention, because I remember the start of my career, it's probably 2 weeks into me being an attending. We had a patient who had multiple gunshot wounds to the liver, not quite the same thing, but to the extent that, we actually considered, or the patient became a candidate for transplant because they went into fulminant failure like that. And I remember I wasn't actually directly taking care of the patient was on the team, but sounded very similar. And the patient needed to be transplanted ultimately to survive. So I just brought that back. Sorry.
Well, this paper, interestingly enough, because I went spelunking through PubMed to educate myself about this, that paper that was written in 93 described a series of 36 patients in total over a number of years. And a couple of them were that same situation, profound liver trauma leading to this syndrome.
There you
So
go.
our transplant team, later day 1, so the morning of day 1, we get the biopsies, realize that this is not going to work. He gets sick over the next 12 hours, profoundly more unstable. So that evening, back to the OR at 2300 on that day, he's anapatic. And they bring him back to the ICU. And amazingly enough, initially he gets more stable. He comes down on one of his pressors. We're on 3 pressors instead of 4. Things start to get a little bit better. But now there's no liver, and it's not 100% true anymore, but all of my attendings from all of my training have always said, we have lung machines, heart machines, kidney machines. We don't have a liver machine. So what are your thoughts? How do we keep this guy alive?
Yeah, in our hands, we would be using Mars on this guy.
Yep.
And he would get that until he got his liver. And there are reasonably good outcomes with that strategy. Otherwise, you're just running around again, FFP drip, dialysis, CRRT for the kidney injury or the kidney disease, acute kidney
Syndrome.
injury that he has. And praying he's number 1 on the list for the liver. But he's only going to be able to be managed like this for maybe a couple of days, because what happens is they tend to get you get infectious issues that creep into the problem. And then with the immunosuppression, they never get out of the infectious triangle.
So yeah, the first question we had to answer is, can we relist him? Will he survive a second transplant? So early that morning, the next morning, we got an echo. We found new heart dysfunction, EF at 35%, but cardiology evaluated and said, we think he'll tolerate retransplant. Did a CT of the head to look for cerebral edema. He did not have any. So neurocritical care evaluated and said, we think neurostatus is okay. He was relisted status 1A that morning. And so now it's the Crit Care Olympics. So we don't have Mars at our institution. So we were doing the running around as you described. So we did Q2 labs and we were looking at all of the things. We were doing Rotems and ammonias every 4 hours. We were monitoring pupils every hour. We had him on multiple drips. We had him on FFP, bicarb, 3%, 20% dextrose, and then 3 pressors. We were supporting the right heart with epoprostenol through the vent. We had goals for sodium. The driving of the sodium was predicated on the idea that it's going to help prevent cerebral edema from the anapathic state. We targeted fibrinogen and INR at specific levels, platelets above 50 and hemoglobin. CRT we were definitely on, and we were running it between 6 and 8 liters to manage the acidosis and the electrolytes. And then we did Plex every day to try to manage the coagulopathy. And
was there any discussion? Now, I feel like once you've actually done the liver, you kind of, if everything is okay, you're obligated to try again. That being said, was there any discussion with the family about, because it brings in, important questions, right? Is this a sort of Hail Mary because we have to? Is there any discussion about, and I hate to say this, but goals of care with this patient in particular, since even though you don't see edema, you're not quite certain that his neurostatus is going to be 100%. Was that discussed?
It definitely was. There were extensive discussions with the family, both, before the rescue hepatectomy was performed and during this period while we were searching for a liver. And the family wanted to proceed, and the transplant team felt that he was going to be able to tolerate retransplant and hopefully with a good outcome. But there were definitely those discussions being had, just because we could, should we? And the night of day 2, early morning of day 3, and as Dr. Coleman mentioned, may or may not have been the transplant person. I may or may not have been the SICU fellow that night. And we started to lose ground early morning, day 3. Pressure requirement went up. CRRT was running at 7 liters. I couldn't go up any further than that because we were having trouble with electrolytes running at that rate. And he began to bleed. We had more than a liter out in less than an hour. So the next question became, now what?
Well, I presume at this time you had pretty strict targets for all of your coagulation profiles. So I'm guessing that you were meeting your targets and was bleeding despite that.
So we were meeting all of them, and then things kind of changed. And so I started running more tests.
Mm-hmm.
So,
at this point, we knew we had a liver.
Oh, you had a liver. That was going to be my question.
They were going to get a liver. So we knew that we were going to have a liver that day if we could keep him going another, 8 hours or so.
Yeah, because, it's funny because as I move further on in my career, my answer at the beginning would be different from my answer now, which is going to be, should you, right? It's almost like game is over. I hate to say this, but you're bleeding at a liter per minute with everything that you're doing and with all the resources that are being put. And I'm not speaking as an individual patient because that is hard, right? But if we think of the global picture of the 20 other patients waiting outside, is this the correct thing to do? I don't have the answer for that, but I do think that that would give me some pause because we can get very focused on the person in front of us. And I'm not even sure that he's going to survive the new transplant. What do you think, Dr. Henry? I mean,
Is this a high-risk patient? Yes. If you're in, if you've made the decision that you are in, they've walked this road, that had the discussions, decided that a new liver makes sense. Suppose this is just, a stitch that pulled through the IVC and he's bleeding from the IVC and it's something very fixable, but it's a big deal because of his tenuous nature, but it's something very fixable. Wouldn't you want to take a look and make sure of that before you declared no go? I can see making that decision in the first 24 hours after all of this happened and so on but I get you've really poured some resources into this now, and if there is no other hard no, nothing to make you think he's going to be completely brain dead, all of those things, I think you have to go look.
I would agree. And if you know a liver's on the way, you can take him to the OR, pack him,
Yeah.
transfuse him,
Yeah.
and like you buy time.
Yeah.
if the liver is on the way, right?
Mhm.
Yeah. And one other quick question. It's the other thing is I would approach this also with like the way we do for a spleen. Do we take it out or not, right? So somebody comes in, they have a grade 4, grade 3, whatever spleen, and you say 2 units and then you go. So I would have actually set parameters a priori because it's easy to fall off that, well, we've decided those are our goals and then we change them as they go on. So I would set parameters and saying, if this, then that, and if he doesn't make XYZ, then we stop. I would have started that. I would have said that way before, just as an FYI, for me. Anyway, so what
So
happened?
as you kind of alluded to, we were in for a penny, in for a pound at this point. So we drew more labs. I did wake the transplant team up and told them, we're losing ground. We're out of time. Y'all got to come in, and they did. They were getting ready to take him to the OR when, between resuscitation and ROTEM guided resuscitation and doing all of these things, the bleeding slowed and then ultimately quit. And we kind of got in a little more stable position. We repeated Plex for the coagulopathy. Things got better. Repeated, make sure that the heart wasn't worse. Here we go to the OR. And they go to the OR that day for retransplant. His total anhepatic time until perfusion of the hepatic arteries for the second liver was 48 hours and 15 minutes. But he survived the transplant. We thought we had won the
Fantastic.
game.
Oh no, he died.
Unfortunately, we thought we had won the game. And for 3 weeks, we thought we won the game. He was extubated, or he had been trached, but he was talking. He was coherent. He was not encephalopathic. But as you alluded to very early on, I think it was you, Dr. Henry, that the anhepatic state, you introduce infection problems. And so he got candidemic, and then he developed invasive candidiasis. And he was the one that asked us to stop.
Yeah.
Oh, that breaks my heart.
35 days after a second transplant, he transitioned to comfort care and he expired with his family at his bedside.
I have to give you massive kudos for the way this played out, because this was extremely resource intensive and physician at the bedside intensive to manage this. And it sounds like all along the way, you managed expectations, goals of care, honoring the patient's wishes, family's wishes. And I just am imagining this family knowing that he was the one who said, I've had enough, instead of the family making that decision early on. I hope that the family has some peace about the way that this played out, even though it had a very poor outcome, that they did have some time with him, and that they got to kind of make that decision together.
I also like I like the collaboration, though, the immediate responsiveness with the the transplant team and the fact that they also respected the ICU's management of the care and didn't, because sometimes that can be tricky. And, it sounds like everybody worked together. It is unfortunate. Did he not have antifungals initially? Yes or no?
He was on micafungin from the time of the first transplant.
Okay.
And so he had developed what was later speciated out and found to be a resistant organism. Yeah.
Hmm.
And I think his family was able to get some peace. Actually, his sister, the night before his second transplant, was there the entire night, and was there. And I think they saw kind of how hard everybody was working to try to get him a good outcome. But they got to spend time with him. And like I said, after the second transplant, he did have a good neurologic function, was able to interact with his family. So we got him some time.
Unfortunately, we are out of time. We did have one more great pancreatitis case that we were going to talk about, but this has been just fruitful and lively, and I've learned so much. I appreciate all of your time. One last note for the participants, a reminder to submit a sign-in sheet to the AAST office by Friday, June the 13th. That's all we have time for today. I really appreciate everyone who participated, and have a lovely evening.